Good evening, everyone. Today we are going to discuss hair fall, medically known as alopecia, one of the most common yet frequently mismanaged conditions in clinical practice. In this session, I will take you through a structured and clinically relevant approach from basic physiology to diagnosis and management so that you can handle this problem logically and confidently. Why hair fall is important? Hair fall is not merely a cosmetic concern. It carries a significant psychological burden. Patients often present with anxiety, reduced confidence, and even social withdrawal. From a clinician's perspective, the real challenge lies in its multifactorial nature. Very often, patients are treated symptomatically without identifying the root cause, leading to persistent or recurrent problems. One very important clinical concept, hair loss becomes visibly noticeable only after approximately 50% reduction in hair density. So, when a patient comes with visible thinning, the process has already been ongoing for months. This highlights the importance of early recognition and timely intervention. In a healthy individual, around 100 to 125 hairs are shed daily as part of the normal cycle. During washing, especially if not done frequently, these numbers can go up to around 200 hairs. So, simply counting hair fall is not enough. We must always correlate it with pattern, duration, and associated features. The most important principle to remember, hair fall is not a disease, it is a symptom. It reflects an underlying issue, which may be systemic, hormonal, nutritional, or local. So, our focus should always be on identifying the cause. Clinically, hair fall can be divided into two major categories. First, true hair loss, where hair is shed from the root. Second, hair shaft breakage, where the hair breaks from the shaft. The distinction is crucial because it completely changes our diagnostic approach and management. In true hair loss, the shed hair has an intact bulb. This indicates a disturbance in the hair growth cycle. It is usually associated with internal causes such as systemic illness, hormonal imbalance, or nutritional deficiencies. In contrast, hair breakage involves damage to the hair shaft. The hair falls without a bulb. This is usually due to external factors like excessive heat, chemical treatments, or mechanical stress such as overstyling. To understand hair fall, we must understand the hair cycle. The anagen phase is the active growth phase. The catagen phase is a short transitional phase. The telogen phase is the resting phase after which the hair is shed. Any disruption in this cycle leads to abnormal hair loss. When hair loss is diffuse and non-scarring, internal causes should be considered. The two most important conditions are Anagen effluvium and Telogen effluvium. Anagen effluvium is characterized by sudden severe hair loss. It occurs due to direct damage to actively growing hair follicles, most commonly seen in patients receiving chemotherapy. The onset is rapid and the hair loss is often dramatic. Telogen effluvium is the most common cause of diffuse hair fall. Here, a large number of hair follicles prematurely shift into the resting phase, leading to excessive shedding. The mechanism is simple. A triggering event causes multiple hair follicles to shift into the telogen phase simultaneously. After a delay, these hair shed together, resulting in noticeable hair fall. A key clinical feature to remember: there is usually a delay of around 3 months between the triggering event and onset of hair fall. This is extremely important while taking history. Common triggers include physical stress such as illness or surgery, emotional stress, hormonal changes, especially postpartum, endocrine disorders like hypothyroidism, rapid weight loss, and certain medications. Identifying these triggers is the cornerstone of diagnosis. Telogen effluvium is usually self-limiting. However, regrowth takes time and patients must be counseled properly to avoid unnecessary anxiety or overtreatment. When hair breakage is suspected, we should evaluate external factors such as excessive heat styling, chemical treatments like coloring or straightening, and mechanical damage from tight hairstyles or aggressive combing. Traction alopecia results from chronic pulling forces on hair. It commonly presents as thinning along the frontal hairline and is often reversible if identified early. A structured diagnostic approach includes detailed history, especially looking for triggers, clinical examination, and targeted investigations based on suspicion. The hair pull test is a simple bedside tool. If more than 5 to 6 hairs come out on gentle traction, it indicates active shedding. Now, the lab investigations. Basic investigations include CBC to rule out anemia, thyroid function tests, liver function tests, and ANA if autoimmune causes are suspected. These help identify underlying systemic conditions. The most important principle of treatment: always treat the underlying cause. Symptomatic treatment alone will not give long term results. General management includes ensuring proper nutrition, lifestyle modifications, and most importantly, patient reassurance. Counseling plays a huge role in management. Topical minoxidil may be used in selected cases to promote hair growth. However, it should always be combined with treatment of the underlying cause. Patients should be advised gentle handling of hair, use of conditioners, avoid excessive heat and chemicals. These simple measures can significantly reduce damage. The golden rule: the less you manipulate your hair, the healthier it remains. Overstyling and overtreatment often worsen the problem. To conclude, hair fall is a symptom, not a diagnosis. A structured approach helps identify the cause, and logical, cause based treatment ensures the best outcomes. Always remember, treat the cause, not just the hair, and the results will follow. Thank you.